Good afternoon, everyone. I know we'll continue to have people join us, but wanted to get started because I know, as always, we have a pretty significant amount to cover today. Really glad to have you here today. I'm Robert Stiles with Telehealth Rocks, and we want to let you know before we begin that the session is being recorded, and we'll share it with you afterwards. Your microphone is muted. You can unmute it or use the chat to talk. Your completion certificates will be mailed next week after the series ends. This is a 3-session echo. It's important to sign on with your first and last name so we can identify you for the certificates. You can rename yourself by using the 3 dots on your Zoom screen if your full name isn't visible. So I'd like to introduce our speakers for today's session. We have Erin Hambrick, who is a clinical child psychologist, Melissa Maris, who is a clinical community psychologist, Joe Williams, who's a clinical psychologist, and Alice Zhang and Alana will be helping us in the breakout rooms. So just to remind everyone, we try to use first names. We have some amazing participants as well as presenters, but everybody enjoys first names, and that helps with the didactic function of the session. So I'll hand off to Erin to start our discussion today.
Hi, welcome back, everyone, and thank you so much for coming. As usual, we don't have anything to disclose. We hope to be, our goal is to bring the best available evidence that we can, and don't have any disclosures to report related to what we're presenting. Next slide, please. So today we're at session 2 of this 3-part series, and our focus today is going to be generally not only what to expect from a trauma responsive mental health provider, but really how to collaborate with trauma responsive mental health providers and ways that we can all be on the same page in the service of helping children and families. Next slide, please. In terms of session overview for today, it's going to look really similar to last week. So we will have a didactic presentation split up between myself and Melissa and Joa. We'll do a couple of chair yoga exercises. Around 2 o'clock, we'll transition to breakout rooms and then wrap up with a word cloud activity and hopefully have a little bit of time for Q&A. Next slide, please. So let's go ahead and start with our first chair yoga of the day. So I want to provide some rationale for why I've selected this yoga sequence for today. When working with people who are trauma exposed, sometimes the way that they react and respond to their environment is with a little bit of suspicion and it's really understandable suspicion. People who have lived through trauma have found themselves in environments that have been unsafe. And so especially novel environments, people tend to be wary of those and tend to be on the lookout for how to protect themselves. Layers of sound is an activity that you can do to really help people orient to the environment that they currently find themselves in, which can be useful for people who need a minute to settle in and really want to gain an awareness of their surroundings so that they can settle in and hopefully begin to feel safe. Another reason I like using this exercise with people exposed to trauma is that sometimes in yoga and mindfulness sequences, we often prompt people to pay attention to their breath and to notice their breathing. But people who have lived through trauma often find themselves with, this doesn't apply to everyone, but sometimes when we tell people who've been trauma exposed to focus on their breath, that quietness and that awareness of their breath can sometimes at first lead to some anxious feelings and can lead to sometimes an awareness of, oh, wow, my breath is more rapid than I expected. And so something I like about this is that it orients people to the present moment, but kind of avoids orientation to the breath, which is not always bad, but sometimes not necessary in order to induce mindfulness. So go ahead and find your yoga seat. If you remember from last week, that's really just whatever feels comfortable to you, eyes open or closed, feet on the floor, legs crossed, any place where you feel you can settle in for a moment. And once you've found your yoga seat, I want you to really pretend that you're stretching your ears as far and as wide as they can go so that you can hear the sound that is the furthest away from you. Maybe it's outside of the building. Maybe it's far away down the street. But when you stretch your ears, what is the sound that you can hear that is the furthest away? And now bring your ears in a little bit. What is the sound that you can hear that is a little bit closer by? Maybe it's inside the building that you're in. And now try to notice a sound that's close by, that's inside perhaps the room that you're sitting in. Maybe it's a soft sound. Maybe it's loud. Maybe it's that grating sound of the fluorescent lights. Just notice it. And finally, take a moment to notice a sound that's inside your own body. What sound can you hear? And now settle into the space that you find yourself in as we move forward. Next slide, Christy. Feel free to, we have a lot of session to cover today, but, feel free to place in the chat any reactions or thoughts that you have about that activity. Maybe if there's a subset of people that you work with that you think it might be useful for. But I'm gonna pass the baton over to Joa here, who is gonna kind of close the loop on some things that we were discussing last week, especially related to these principles of trauma-informed care and how we manage them when sometimes one principle might seem at odds with another. So Joa, you can chime on in.
Yeah, thank you, Erin, and thank you for walking us through that activity very much. Yeah, and welcome back, everybody. It's good to see everybody here again today. And I wanted to take just a few minutes to get us started today by reviewing the principles of trauma-informed care, as Erin said, and talking a bit about some things that came up at the end of our last session last week, and just reorient us to the basics of these principles, because I think that reminding ourselves of the principles of trauma-informed care is going to be important for all of us, whether we're working with folks at tier 1, tier 2, tier 3, or anywhere else as part of a system of interconnected support, right? Or as an interconnected system sort of model where we're working to actively connect trauma-exposed youth and families to care. And so the main principles that we talked about last time that are important for all of us in interconnected systems are, again, safety, right? Ensuring physical and emotional safety. And so making sure that folks feel safe in the environments they're in and feel emotionally safe disclosing things to us as professionals and as part of their community that they're reaching out for help and support from. And I think related to that is also the idea of trustworthiness and transparency, right? Making decisions with transparency and with a goal of building and maintaining trust for everyone involved in a system, right? Particularly when we're talking about clients and families and children and families. Peer support's another important principle that we want to keep in mind. Utilizing the client stories, patient stories, family stories, right? To try and promote healing using their lived experiences. A fourth principle that we want to keep in mind is one of collaboration and mutuality, making sure that we remind ourselves that we all have a role to play in the healing process, whether that's through initially being the person that connects someone who's been exposed to trauma to higher levels of care or more tiered support as part of an interconnected systems framework, or whether we are working with folks at tier 3 and are trauma-informed mental health professionals, right, who are actively working to help support the children that you might be working with in your classroom. We all have a role to play, and we want to make sure that we collaborate together in that effort. So that's going to be a big theme of what we'll talk about today and again next week as well. Empowerment, voice, and choice, right? Recognizing the individual's strengths can be built on and validated. We all have our own unique individual perspectives on this work, and we want to empower each other and empower the folks we're working with to use their voices and promote resilience in that way. And applying all these principles, being mindful of cultural, historical, and gender issues and biases that can lead to very significant inequities in care, right? If our systems aren't adequately prepared to respond and recognize the biases that are inherent in our systems, right? So, and even as individuals, we need to be mindful of those things. So I think at all levels, right, as individuals and as individuals working with systems, we need to keep these principles in mind. And so that's something that I think we have to think about. Sometimes it's not always going to be clear what to do, because it can seem that some of these principles conflict with each other, right? Or sometimes it can seem like it's you've kind of got two principles that are kind of suggesting two different approaches, and you're not exactly sure what to do. And that's going to come up a lot, I think, when we're working with folks at different levels of these interconnected systems. And that's certainly true with one of the very first things that you can expect from a trauma-informed mental health professional. Because whether we're talking about a trauma-informed mental health professional, or whether we're talking about probably most of us on this call, the vast majority of us are mandated reporters. And if you're working with someone who is a trauma-informed mental health professional, they will also be a mandated reporter. And that's one of the very first things that I think you need to know and expect from a professional that you might be working with, who's working with kiddos in some of the different settings where all of you are working. So if we think about how some of these principles inform what you can expect from folks, and then just sort of be mindful of how to resolve conflicts or perceived conflicts between principles, let's just start by thinking about some issues that can come up with mandated reporting. So if we can go to the next slide. Let's click and go to that. So what do we mean by mandated reporters, right? Well, in both Kansas and in Missouri, teachers and mental health professionals are considered mandated reporters. So for all of you that are educators working in school systems or mental health professionals, we're all mandated reporters, and that really means that we have a responsibility, right? We have an ethical and legal responsibility to report suspected abuse against vulnerable groups, including children, right? So if we know that we have reason to suspect that there's abuse happening against a child, or if a child or adolescent or young person tells us about abuse that's happening, we have a responsibility to report that, right? And that's certainly true of mental health professionals as well. So you can expect that from anyone that you might refer to care, right? So if you refer someone for a higher level of care, mental health professionals are going to be listening and making decisions about whether or not to report any trauma exposure that might have happened. I think it's also important to just note as well that mental health professionals need to disclose this role as mandated reporters to the families that they work with as part of the process of obtaining consent for those services. So that needs to be discussed with folks up front, right? And part of that is just kind of reminding people about the importance, and it kind of goes back to the principle of transparency, right? Trustworthiness. We want to be transparent with folks, and we want them to know what our role is and what the boundaries around our roles are. So, and just sort of reminding ourselves of the importance of these principles. That applies too to being mandated reporters. It's also, I've read literature that also suggests similarly that as teachers, right, it's important to disclose your role as mandated reporters, of course, in developmentally appropriate ways, depending on the age of the children that you're working with, but just as soon as possible, right, so folks know what to expect. And just remember, you only have to suspect abuse, and if you are aware of a situation and you're not sure what to do, you can always, if you're in the state of Kansas, you can always call the Kansas Protection Report Center, 1-800-922-5330, this number here. And you can just do a consult. You can do a confidential consult if there's a situation you're not sure about, and they can help you make determinations about whether what you're dealing with is reportable or not. And it's always better to err on the side of just, I think, getting more information, right? So collaboration when we think about those trauma-informed principles. So we want to make sure that we do that. Yeah, and Carrie, I see that you said you make sure that you do that during the initial consent and then assent, right? Yes, I think absolutely. And that's something we just want to be transparent about up front. But unfortunately, for those of you who've ever been in a situation where you've had to report, right? Sometimes you've probably seen situations where it seems like the decision to make a report, right, even when we follow our legal and ethical responsibilities to do so, can create perceived conflicts between some of the principles of trauma-informed care. So let me just give you some examples of that and think about how we can handle these kinds of scenarios. And we're not going to fully walk through all of these today because we don't have time to get through all of this. We could actually spend an entire workshop on mandated reporting issues. But I just want us to think about how we can resolve perceived conflicts between principles of trauma-informed care using this as an example. So if we go to the next slide, let's just think about some things that might come up, right? So sometimes, mandated reporters might find themselves again in situations where it seems like there are perceived conflicts between principles of trauma-informed care that can come from making decisions around reporting, right? So a common example of that is that when we're making a report, sometimes we might have concern that reporting abuse will result in retaliation against the child. That can be a concern, especially if we know or we have specific information to suggest that a perpetrator who's perpetrating abuse against the child is still in the residence, still in the house, and has a history of acting violently against the child in some way or another, right? So that can create some real concerns, right? On the one hand, protecting the child's safety is absolutely our number one priority in this case. But we want to also make sure that the child's safety isn't compromised, right, as much as we can through making reports, right? There can also be some concerns then that if we report, right, and that we are reporting in a way that's entirely confidential, which you can, that can then erode trustworthiness with the family that you might be working with, right? So what do we do in those kinds of situations? And I think we just have to go back and remind ourselves again, what principle is really taking priority here? If there's one principle that really takes priority in the implementation here, what would it be? And in this case, of course, right, safety. We want to make sure that we ensure the child's safety. And so I think there's always that balance. And then we can often draw on other principles in the sort of model of trauma-informed care to help us resolve some of these conflicts, right? So even when there are perceived conflicts regarding safety and trustworthiness in this scenario, for example, we can always remember that the principle of empowerment, voice, and choice, right, speaks here to helping us empower the child that had the confidence or had the courage to come tell us as a trusted adult that they were experiencing something threatening, dangerous, and scary in their own life, right? And so by helping empower that child and keeping the priority principle of safety in mind, we can start to think about how we can begin to resolve these issues. Sometimes we're working with families who maybe have had other experiences with social service agencies responsible for investigating reports. And by virtue of communities that they're a part of, maybe they're part of a historically oppressed community or an oppressed community that's actively being oppressed in the United States and have had negative experiences with social service agencies, there can be perceived conflicts between cultural issues and safety in that regard, right? But thinking again back to our role, collaboration, mutuality, and empowerment, I think we can always remind the folks that we're working with, we're going to be here to advocate for you. Just because this report starts here doesn't mean that we're not going to be here to support and advocate for you when you're working with the systems that are involved in helping ensure everyone's safe, right? So I think we have to draw on other principles to help resolve perceived conflicts. And this is something that I'm just using here as using mandated reporting to give you some examples of, but we'll want to be mindful of that as we think about what other kinds of things you can expect when you're working with trauma-informed mental health professionals. So I'm going to hand it off now to Melissa, who's going to talk a little bit about some other things that you can expect from trauma-informed mental health professionals. Again, all responsibilities and roles that rely on those 6 principles that we've already talked about. So Melissa, I'll hand it off to you.
Thanks, Joa. And if we can go to the next slide, Christy. So actually, Erin, I think this is coming. We're just going to whip it right back around.
This is mine, but you're next. You're very
okay.
next.
I'm ready. I'm ready, Erin.
I sent everybody curveballs today. We're coming in and out of the conversation more than usual today. Hopefully that'll keep us all on track. So similar to what Joa just covered, one of the first things that will or arguably should happen when a child begins receiving support related to their history of trauma is that typically an assessment of what happened and when it happened, or the multiple things that may have happened, is going to occur. When I have conversations with people who aren't necessarily, licensed mental health providers, what often comes up is, do I have to know that the child was exposed to trauma? Do I have to know the nature of their trauma exposure to be providing supports that are trauma responsive and informed and trauma aware? My answer to that is really always a resounding no. Now, I think it can be useful to know a child's trauma history in many ways, but one thing that we know is that when we use trauma responsive and informed principles, we are helping children who are exposed to trauma the most, but we're also helping other children. These are good principles of interacting with one another and fostering safety, and perhaps even preventing potential traumas like bullying, for example, within the school setting. So I never want people who aren't licensed behavioral health providers to think, gosh, in order to make referrals, I really have to know what happened to the child. You don't need to know the details. Now, many times you're the trusted adult who the child actually wants to share details with. And that's a privilege and a responsibility all at the same time, but that's never the expectation, because that really is something that will happen once you get the child to services, and that can and should happen in a comprehensive way. In addition, I also just want to note that there can be some drawbacks to doing trauma assessment outside of clinical settings. This isn't to say that they can never occur within the schools, but if it does, it needs to occur thoughtfully. For example, some people have noticed that, knowing about a history of ACEs can be helpful in terms of individualizing supports. And while I totally agree with that, we never want to do things, for example, like screen for adverse childhood experiences across everybody in the school, right? And send out some sort of mass survey that happens kind of in an unsupervised fashion where people aren't necessarily sure how that information is going to be used. You could see how, even if you tell people, hey, this is going to be anonymous, those can be difficult questions to read and to respond to. And you really want that process to be as individualized as possible. In addition, we've learned a lot about how if staff, if teachers, if mental health providers, for example, have histories of traumatic experiences themselves, that can kind of lead to situations where, maybe they are better able to respond in certain situations, or may not really be wanting to respond in other sets of situations. And that, I think, led to some misinformation around, oh, well, we should, screen our staff, for example, for their histories of trauma. But really, we have learned that makes people feel unsafe. It makes them wonder how people will judge their work performance. And so even though trauma really matters, that doesn't mean we need to go out and be kind of mass evaluating how trauma exposed a certain school or a certain organization might be. Screening for trauma by mental health providers or others who have a strong background in how to do this ethically and in a trauma-informed manner really does often occur as part of routine mental health services, regardless of the referral. So you might refer a child, and trauma might not be on your radar, but often via the fact that you've referred them, they will have access to supports that will look and see if that's part of the picture. This type of assessment happens best when it centers child voice. It can be difficult for children to talk about their experiences. And I think what's often more difficult is when people act like the thing that happened to them is too scary to even talk about, right? So it's definitely a balance. We don't want to tiptoe around things such that kids are thinking, gosh, even the adults can't handle hearing about this thing that happened to me. That must mean it's really, really bad. So we do want to ask children, and we do want to hear their perspectives. It's also good practice, again, as part of these tier 3 services, for providers to assess not only what happened, but when it happened, how old the child was, what their understanding of what happened was like at the time it happened, and how their understanding of it may have changed. It's good to know how frequently the event has happened or how severe it was, because all those things can really give us clues into kind of reasons for children's behavior. You know, a lot of time children end up getting referred for tier 3 services because sometimes the ways that they act are difficult to predict and are sometimes the patterns kind of don't line up. People are thinking, gosh, I really don't understand why the child reacted or acted in the way that they did. It's inconsistent with how they normally behave, for example, is what people might say. And a really good assessment of what happened can often give insights into those behavior patterns. And again, really highlights why we have to be working together, because behavioral health providers have really good training in how to assess for these things, and then how to collaborate with others who are working with the child and family to say, here's what we know, and here's with our releases, and, you know, with my work with the patient on collaboration and transparency, you know, here's what I can share, because here's how I think it will help your work with the child. I also want to note that it's also really good to assess benevolent or positive child experiences, because that really gives us a sense for how many resources are available in the child's environment to draw on, and can really help keep us having that strengths-based focus, even when we know that trauma has been part of the picture. All right, so I'll stop there and pass it back over to Melissa.
Thanks, Erin, and good afternoon, everyone. We're so excited you're back here with us. So we wanted to talk just briefly about kind of the clinical side, the intervention side, when we were talking about tier 3 supports within a multi-tiered system of support focused on trauma. And so when we are, again, talking about these tier 3 interventions, I think it's always just a good place to pause and remind ourselves and kind of revisit that when we are talking about tier 3 interventions, we are talking about intensive interventions for a few, a relatively small number of young people. And there are a number of interventions out there designed and tested for young people, individual and groups, in a variety of settings around trauma. You'll see the link here to the National Child Traumatic Stress Network's treatment and practices website. Trauma-focused CBT, TF-CBT is one of those interventions, but there are several. But a lot of times what we find is that in practice, there are a lot of different things that people are doing in terms of these tier 3 trauma interventions. And so we want to talk about this kind of in a general way here. So one thing is that when we're looking and we're maybe collaborating with someone, we're in a school, we're collaborating with a community-based provider, or someone in the community is connecting to school, families in schools. Part of what's going to be kind of your look for in terms of, what's happening here in terms of trauma is looking for a treatment plan. So really looking for a very concrete kind of indicator that assessment that Erin talked about has happened in some way, that information has been gathered, and then that the rest of kind of the pie, the PIE, has been filled out. So there's a plan, right? There are clear goals for treatment. There's an idea of how those goals are going to be reached, and that there's an idea of how we're going to know when we reached those goals. That's going to be kind of the sign that there is kind of a very clear treatment plan, potentially around trauma. And the reason I say potentially is that one of the reasons that, and one of the ways that trauma and the treatment of trauma becomes pretty tricky is that when, say, as a school, we refer a young person to an internal or an outside mental health professional, we're saying, hey, here are the things that we're seeing. Can you help? right? And so then we're handing this over, we're kind of passing the baton to another professional who's going to take that baton and then kind of go ahead and try to collect their own information. And we, as the people who are referring that young person for additional services, have a lot of great information that we can share. And they, as the treating provider, also have information that they're going to seek. And so as they're developing that treatment plan, they're going to learn about a whole bunch of stuff, hopefully learning about trauma history, kind of as Aaron was speaking to, but also learning about other kinds of things. And so when we think about kind of complex challenges, kind of in the role of trauma, we kind of get into a little bit of a chicken and egg issue. And what I mean by that is that it's possible that we might refer a young person for treatment, and in our heads, we're thinking about it as being related to their trauma. They get into therapy or a therapeutic situation, and then actually the treatment plans ends up looking like something a lot different, right? So it could be something like trauma-focused CBT. Something happens, we refer for treatment. There's this very clean, neat intervention around the trauma that happens, developing skills, putting supports in place, and that's very clear. And or in the understanding of kind of the broader context of what's happening, that outside provider might determine that there are other things that actually need to be addressed or established before we can even get to kind of this other piece of this trauma component. Young people, all humans are complex. And so really when we're thinking about these complex challenges, we have to think about complex systems that need to be in place to support kind of these continuous change processes. If we can go to the next slide, please, Christy. So the trick here with all things and is to, as a professional, as a grown-up involved in these scenarios, is to be patient, be clear, and to be proactive. So ask questions of other professionals, and it is appropriate to expect that other professionals, if all, kind of information is flowing in different ways, that you should get a response in a way that makes sense for you in your role. So part of the question that I often get from school friends is, so we have this young person who may or may not have experienced these difficult things. Now they're in treatment and they're getting some kind of intensive services, some kind of behavioral health services. What can I do? Right? So something is happening and else is happening somewhere else. What can I do? And this is really where the trauma-informed model and trauma-informed schools kind of really shines. Is the great news, and it's what Aaron was just talking about, is that what we do when we are being trauma-informed in a classroom is good for all of the kids, right? And that's really part of the value of really emphasizing these universal approaches, is that schools really were designed for all, and then also some and a few. So schools kind of have to do all levels of that. But the easiest and best way to reach everyone is to start with the all, right? Because the better that all is, that universal intervention is, the easier it's going to be to address the some and the few. And so really thinking about what kinds of supports can be in place, what kind of skills can we teach that benefit everyone no matter what. And when we're doing those things, it's going to support whatever that outside treatment plan is. And when it boils down, kind of what can you do? The first thing is, you don't want to do any harm. You don't want to, do anything that's going to make it worse. And so kind of going back to those basic trauma-informed principles and kind of these three sorts of pieces. These are my go-tos when I say, if nothing else, try for these. So the first one, being consistent and predictable. Consistent and predictable. We are all better functioning. We're better people when we are in consistent and predictable environments. And so I put the picture of the Roomba up here. It's an analogy I use a lot in my professional work and personal. It's just kind of thinking about humans, and especially young humans, as kind of being kind of like little Roombas, right? And it's kind of twirling around and going in different directions, and they learn how to turn around and go somewhere else by bumping in to walls and to different things. And so we need to have those walls in the same places so that when young people can get, bump up against those and kind of come up against expectations and rewards and consequences, very consistent and predictable environments, that we learn how to navigate those environments a little bit more successfully. And especially when we're talking about young people with trauma histories, we're talking about young people who have grown up and live in environments where there might not be any walls. The walls might be really, really close together, or the walls might move, right? And so being able to provide that consistent and predictable environment is incredibly, incredibly helpful. Focusing on safety. So safety, 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 safety first. Kind of one of the things that we talk about with trauma-focused work is that without safety, none of the rest of it really matters. And the reason we say that is because without safety, our brains are not in a place where we can really consistently take in information, encode it, remember it, and use it. And so if a young person feels unsafe, then kind of that's a full stop. Like, so stop there and try to establish safety, because without that safety, the rest of it really isn't going to stick. And then finally, relationships. And so we know that repairing kind of a history of trauma and these challenging experiences really does happen through these safe relationships. And this is one of the values that I've always really seen with schools, is that schools, just by the nature of kind of being there and happening, are consistent and predictable environments, typically very, very safe. And again, a lot of opportunities for these high quality relationships, even just in the day-to-day business of, doing school. And so again, kind of remembering these as a go-to, regardless of what else is happening in treatment, whether it's trauma focused or not, whether it has trauma connections, whether trauma has happened at all. Any kind of outside sorts of behavioral health, mental health treatment is always going to be benefited if young people are coming to schools that are consistent and predictable, where safety is prioritized and relationships are kind of centered in everything we do. So with that, I will hand this back over, Erin, to you for our next steps.
Well, this one's Joa's, but I had something I really wanted to say to piggyback off of the Roomba, which I loved. I saw Alice chime in there. It really strikes me that when we find or kind of decide that a child could benefit from Tier 3 services, some of the first things that happen aren't inherently trauma informed, right? We add more people to the team, typically people who the child and family are not yet familiar with. And novelty is hard when you've had a history of trauma, because novelty is a potential signal that things might not go the way that you expect, that you might not be able to predict what's happening next. And so it is so key in those moments where we decide, we need to bring some additional supports on, that we start slow. We don't just throw everything at the family all at one time, and that we are thoughtful about who should play the role in those supports. Maybe there is somebody they know who could be this additional support, or that, the first time we're meeting with those people or talking with them, that people that the child and family do know are CC'd on those emails, right? Are, involved in whatever way they can be in these small ways, so that novelty and initiation isn't an additional stressor, but instead is actually a perceived support. So yes, thank you, Melissa. And Joa, back over to you.
All right. Yes. No, thank you, Melissa. And thank you, Erin. And so I think just to sort of recap a bit, when you think about what kinds of things at a big picture level you might expect from a trauma-informed mental health provider, right? Like most of us on this call, or most of us on this echo, trauma-informed mental health providers are all going to be mandated reporters. We're going to be thinking about who do we need involved if it's relevant, if we have to make a report, right, to keep a child safe. So what other additional systems or supports are going to be needed? They're often going to be doing some sort of trauma specific assessment to better understand the nature of the trauma. And again, one of the reasons for that, as Erin was talking about, is going to be to try to think about what kinds of issues are going to need to be addressed in those Tier 3 treatments that Melissa talked about, right? So we're going to be doing some kind of trauma specific assessment to some degree to more clearly understand the nature of what we can about what a child might have gone through. And then from there have to think about, what's a treatment plan. So a good trauma-informed provider is going to be thinking about how do we come up with a plan for intervention, a rationale for intervention, thinking about what path forward is going to make the most sense, thinking about best practice evidence-based treatments for kiddos who are presenting with specific trauma-related concerns, right? So expect that from a provider, regardless of what modality they're using, right? Those are at least things that I think that we should all kind of expect from providers. We're going to be talking a bit just today, sort of informally, and introducing some concepts from one specific tier 3 intervention that was already mentioned, trauma-focused cognitive behavioral therapy, and then talking a lot more about that next week, and thinking about how you can implement some of that. But I think it's just important to be mindful that at a big picture, these are all going to be things that you want to consider. And in line with sort of the idea that we've talked about both today and then last week, we want to think about how to effectively collaborate, because I'll say that as a mental health provider, right, when I've worked with trauma exposed kiddos, I think it's often very helpful to know what's going on in the child's environment, both at home and at school, because we want, as therapists, the work that we're doing in the therapy room, right, or if we're using televideo platforms or video conferencing platforms, right, in the virtual web room, right, regardless, we want to know that what's happening in therapy is translating to the world outside of that therapy environment, right? We want improvements in therapy to translate and generalize to other parts of the child and family's life and their lived experience. So that includes the classroom, that includes what's happening at home. So it's often helpful to collaborate. And so with that, on this slide, I included some things that's helpful for us as mental health providers to know, but I also want to say that, I think it's important for me to say that I think it's helpful for me to share with everyone what I'm doing, right? What my treatment plan is, what some of the specific skills we're working on are, because that's going to be important when you think about how to make sure that, we're all sort of doing the same thing in different environments to help support the child and provide some consistency in things. So I think it's important for us as providers to share with folks what it is we're doing and the rationale for why we're doing it. If we're using a specific emotion regulation skill, right? If we're using a specific behavioral management strategy, what is it? Why are we using it? And how do we sort of share that information with others to create some consistency? But it's also, I think, helpful for you to think about sharing with providers things that are going to be useful for them, right? So if we're thinking about addressing emotional and behavioral problems in therapy, for example, what kinds of emotional and behavioral problems do you see happening in the classroom, if any at all, right? If you're seeing changes, right, whether worsening or improvements that are happening in terms of any emotional or behavioral problems in the classroom, that's often going to be very, very important to share with providers, I think, because providers can use that information to also track treatment progress, right, beyond just using the traditional PTSD symptom measures, for example, that we might often give kids and parents to report on any improvement in symptoms, right? I think we think about mental health treating trauma-specific kinds of symptoms, but at the end of the day, we really hope that that translates into improved functioning and improved quality of life for folks, right? Whether we're talking about kids or adults. And so, are you seeing those improvements happening? Or are you seeing no changes or deterioration? All that's going to be really, really important. When it comes to learning problems, right? What kind of learning problems are you seeing happening in the classroom? And I think it's important to share that with providers so that we can better understand the nature and extent to which trauma-specific kinds of symptoms might be impacting a child's ability to perform in different kinds of areas, right? So if you're seeing that a child that is being treated for trauma-specific kinds of issues is having difficulties concentrating, paying attention, right, often seems really distracted, those are going to be important things to share with the treatment team, I think, because that sort of points us towards more specific directions for thinking about intervention strategies that might be most appropriate, right, during the therapy hour that we have that week and in the coming weeks. So what kinds of things are you seeing there? And that's going to be really helpful to share with your providers. Good evidence-based treatments for trauma-related problems have specific kinds of techniques built in to help address these kinds of concerns. And we'll talk more specifically about what that looks like in TF-CBT next time. But I think sharing that kind of information is often helpful. And then if there are plans for educational supports, if you notice that specific symptoms that have persisted, right, and are negatively affecting a child's ability to learn in the classroom, and there's a need for educational supports or an IEP or something like that, it's often helpful to involve the therapist, again, just to make some specific recommendations about things that maybe we're working on in therapy that can also be appropriate for providing support in the classroom as well, just to make sure that everybody's providing consistent support. And that really creates a lot more opportunity for learning and reinforcement of specific evidence-based principles across settings and contexts as well. And so I think one thing, just saying all that, that's also important to keep in mind, and this is important from both a safety, transparency, collaboration, perspective. When we go back to all those basic principles of trauma-informed care, it's going to be important to make sure that in exchanging this information, right, we always get consent from a child's parents or legal guardians before exchanging information, particularly with any community-based therapist. So if you as an educator or someone else in a different system are working with kiddos, and you're exchanging information about what you're seeing happening, right, with a therapist, especially someone outside of that system, make sure that you have specific consents documented and that you have all of that, that you have all of that tracked, because that's also going to help create, I think, more buy-in between parents, between educators, between mental health professionals, and better understanding about what the long-term goals and strategies being used for the best support of the child are going to be. So I think that we just want to make sure that we do all that in a way that creates better buy-in, protects confidentiality, and ensures trustworthiness, transparency, and safety for everyone involved. So with that, let me just pause here for a second, because I wanted to pose a question to all of you. I've talked about some things that from my perspective are important for me to share and that are also helpful for me to hear from other folks that might be working with kiddo. But what specifically for folks that are here with us today, for friends that are with us today, what do you wish you would hear from others that are involved in the child's care? What are some things that you think would specifically be helpful for you to know in working with trauma-informed mental health professionals that might be connected with kiddos that are part of your systems, classrooms, whatever the case may be?
Yeah, and you can unmute or put it in the chat, whatever feels best.
Yeah, so Janice, yes, I noticed you said what triggers a student might have. So if we, in the context of therapy, know that there are specific things that are likely to upset someone and trigger someone, right? And Sarah, it sounds like from your perspective too, that's going to be an important thing to know. So yeah, absolutely. Thank you for sharing that. I think that's certainly going to be an important piece. If we can learn to anticipate our triggers, right, then we can start to implement plans for how to manage our reactions to them. What helps to regulate? Yeah. So if there are certain things that are really going to help soothe the kiddo that can easily be used and applied in a classroom, why not use it, right? Why not use those things? Yeah, no, I think triggers and thinking about what helps you regulate, what helps soothe you. Yeah, those are all excellent points. Yeah, what strategies you're using to regulate, right? So that can also be embedded at school. So Sharon, thank you for sharing that. If there are specific things that are there, we have to take kind of an idiographic approach to this, I think, to understand what's unique and what works for this child, right? So learning how to manage reactions, anticipate triggers, and think about personally relevant strategies for managing reactions to those triggers is huge. Yeah, what coping skills the child is learning and what the student's learning. So absolutely, Barb, thank you for sharing that. No, I thank you for sharing that. I think these are all really important points, and it's good for us to know, because I think that this creates, just even in us thinking about this, a collaborative environment where we can all begin to think about what's important for us to share, as well as, things that are helpful to hear from all of you as well. So thank you for that. For those of you who have worked with mental health professionals who've been connected with kiddos that you've worked with along the way, if you have exchanged information or collaborated with professionals, I'm curious what kinds of things have been helpful when you've exchanged information with folks, if anyone here has. And maybe maybe folks have not done that before, and that's okay too. But if you have, I'd be curious to hear your perspectives on that. What's been helpful in the past? So maybe this is kind of a new idea, right? And then it's that. So Sharon, you said just be honest and open conversations to share what they're going through and what they have gone through, right? And I agree. I think that can be really valuable. And I'm curious what's been most helpful about that, the honest, open exchange of information. The family background. So, I mean, yeah, so just the honest, open exchange, for example, even in knowing about the family background, can be really, really important, because I think that helps you understand what kinds of supports the child might have in place outside of the classroom, right? For example, what kind of things to be mindful of and what kinds of accommodations or things might need to be made. I think that's all very important to know for sure. So thank you for sharing that. Yeah, from an individual needs perspective, yeah. So just making sure, you know, that we can meet them where they are, and through having open, honest exchange about the systems that are part of the child's life, right? We can begin to better anticipate how to meet them where they are. And so, Megan, let me pull it up. It sounds like you'd mentioned that it's a challenge to consistently communicate with providers. Yeah, and I think that's absolutely true. I think that can be a very real challenge to communicate with providers. What are some of the biggest challenges that you found in communicating with providers?
I have found that oftentimes what the providers see or hear from the family or the child isn't always exactly what we see in the school setting.
Mm-hmm. So you see, so you get very different, the behaviors are more contextualized, right? And so you get a very different glimpse of what the child's experience is.
Yes.
Yeah. Yeah. Someone here, let me see. So having a good plan, particularly, it sounds like a diverted plan is helpful to foster parents, relatives, right? Oftentimes the plan says more training that's really non-specific, right? So yeah, so getting more specific information, I think specificity, right? When you're thinking about a plan of action can be really, really important. And sometimes you don't get a lot of very specific information from providers. And then Jamie, you said it has been helpful when mental health providers share the parents' concerns related to the school, right? And I think that's a really important point. That's an interesting point. Sometimes a change of setting, person to share helps facilitate more conversation and problem solving. And then Sarah, you added here that as a mental health professional, you sometimes find that relating a child's strengths, likes, and dislikes can help people in the school setting and forming connections, right? Probably with kiddos and with families in some ways too, I imagine. I'm curious if there's anything you'd add to that to elaborate on that, Sarah. And you don't have to, that's okay. But I think that's a really good point. I'm curious what kinds of connections you specifically meant there. Yeah, so Barbara, you said cooperation, right? Can only assist in the evaluation of treatment. So absolutely, I absolutely agree with that. It could be a reference point when a child's dysregulated. Sarah, yeah, so thank you for going back in and sort of adding that point. Yeah, I think that just having a good baseline, right? And knowing what's going on and where certain problems are likely to be more contextualized can even be helpful for us as providers, I think, to know, and thinking about specific triggers and coping strategies that are going to be relevant, right? But it's helpful, Rachel, you added this, it's helpful when the school and providers are on the same page with coping skills, behavior plans, et cetera. And I agree. And I think that to the extent that providers can be more specific and can get more specific information from other folks involved in a kiddo's life, right? Because we're all part of the same interconnected system, that's going to allow for a lot more specificity. And I think at least opens the door for us to be more mindful about specific triggers, coping skills, strategies, right? That are likely all going to enhance the kiddo's success across contexts and settings. Anything else that folks would add? And Aaron, Melissa, I don't know if either of you have any thoughts about anything that's said, but these have been great thoughts. And I think help us think about real challenges that can come up in communicating, right? And how to open communication between providers and other folks in kiddos' life across different systems. But any other thoughts that other folks have, or Aaron, Melissa, that you have?
I think the one piece that I just wanted to add in is I do feel like it's helpful when we are talking about how challenging it is, one, just to validate that it's hard because this is hard, right? And so it feels hard because it is. We're talking about, different folks with different areas of expertise, with different kinds of relationships to a child and their family and a context, kind of trying to communicate. So it is very, very challenging. So just want to validate that, and then also say that it is possible. So I've certainly worked with a number of school mental health and school providers and professionals and community mental health providers who've never really seen it work in terms of that collaboration and that connection. And so I just kind of want to offer that glimmer of hope that it can work. It's challenging, but when it does work, it's amazing. And I think there are ways to make it easier and to have that effective communication kind of be put in place. So if you are in a place where you've tried before and it hasn't worked, stick with it. And hopefully we can kind of talk through some really pragmatic ways to facilitate better communication across these systems. Again, it is hard, but it can work, and I have seen it work. And I've seen systems work together more closely to kind of make it work for more and more kids.
Yeah. And, we talk a lot in groups that I work with about how children who are in need of tier 3 supports need a lot of supports, and it's hard work regardless. And so really focusing on how do we leverage the system instead of fighting against the system is going to be important here. It does take time to help. And how can we work together from a systems perspective, use a perspective that's arguably more trauma informed so that maybe we can help get further down the road than we have before. But it is hard. It is exactly where a lot of the hard work comes in. Let's go ahead and skip forward 2 slides. Unfortunately, I think we need to skip our second chair yoga for the day. Maybe we can do it at the end. We'll see if we end up having time, but this conversation was right on point. So we really, in this half of our, the second half of our time together today, we really want to focus on this cross-system collaboration piece. How can we work with each other so that we can really holistically be providing trauma-informed care? I work with a lot of people who say access to care isn't enough. Just finding somebody, a provider out in the community might be useful, might check some boxes, but it certainly isn't going to check all of them. It's this cross-system collaboration piece that actually helps us check all of the boxes. So next slide, please. I was looking around at, we've talked a little bit about the interconnected systems framework, which is a framework that some people who work within school settings are trying to implement to help with this cross-system collaboration. And people who work from this perspective think of tier 3 mental health supports. They really view mental health professionals as part of this broader system, right? So people who work within this framework are saying, we've really got to get rid of, oh, this is my patient. Well, it's my student. Well, this is our child and family that we are working together to serve. And really, if we are, engaging in functional behavior analysis, for example, trying to figure out, what are the antecedents, what are the things that kind of come before a child's problematic behavior in the classroom, right? So some of you have used the term triggers, that might be what we're talking about. If we're really going to analyze a child's behavior in the school setting, let's be doing that in concert with folks who are working with the child outside of the school setting so that we can come up with a concise plan that is integrated instead of a plan for school and a plan for what the family's doing in the community, right? And, sometimes there are multiple systems involved: child welfare, juvenile justice. I mean, in many cases, we're lucky if it's just the school and a community mental health provider who are involved. Next slide, please. So kind of an exercise that I'm going to walk us all through now, and then we're going to do a very similar exercise together in the breakout rooms, is really just an exercise to get us thinking, how could we set common goals, common intervention goals across systems? What's an example of what that would even look like? And, you know, I recognize and appreciate that we're glossing over a lot of really important parts here. Like, how do you as a community mental health provider even get reimbursed for all these meetings with schools, right? How do you even find the time to work that into your day? You see patients at night, the school stuff happens during the day, that doesn't line up, right? I recognize those are huge problems. And I would refer you all back, you know, if you're kind of frustrated by the dynamics at your place of work and the ability that you have, the resources you have for cross-system collaboration. We put some resources into the slides from last week, you know, related to how to create things like building leadership teams and district community leadership teams that can really help from the top down build capacity for this type of necessary collaboration. So I appreciate that in these exercises, we're kind of assuming that you have avenues for collaboration and that you've already worked that out, but we recognize how challenging that can actually be. So let's pretend here for a minute that, you know, you're a school teacher and you've noticed that a child's attention is poor, they're frequently cranky, and 2 to 3 times a week, they're falling asleep during class. And so you have this wonderful, rare opportunity that hopefully will become less and less rare to meet with one of the biological parents and the community-based therapist. So you've been able to work out a time to get together and get your heads together. And as part of that meeting, something that comes to light that's new information for you is that the child recently lost a family member to violence. And kind of given you're kind of learning through this process that the child might actually be pretty sleep deprived when they're coming to school because they are having some nighttime fears related to this experience that's disrupting sleep. So as a group, you all determine that this disrupted sleep is not only problematic because the child is spending a lot of time worried at night, but it's also leading to impaired functioning throughout the school day. You know, attention problems are like the common cold, right? Attention problems can be due to a number of things, and poor sleep quality is certainly one of those things. Crankiness can also go alongside that, kind of overreacting to smallish stressors. And so let's think for a minute, what supports can be put into place at school and what skills can be taught within the school context to address sleep? With supports being things that are available to the child within the environment, and skills being things that we actively try to teach and scale up within the child. So just as an example here, you know, a support could be non-contingent nap opportunities, you know, opportunities that the child doesn't have to earn every day at 10 a.m. and at 2 p.m. The child is given access to a place where they can take a nap, right? You work with the child around, you know, what would a place where you could nap look like? What would make that space safe? Who should be there? Who should not be there? Those types of things. Maybe, you know, really not judging tardies harshly if the parent is reporting, you know, I let my child sleep in, right? Really viewing sleep as primary. Those can be examples of supports that can be put into place. In terms of skills, you might work with the child on what might make them feel comfortable in terms of asking for nap opportunities. Do they want to raise their hand? Do they want to tap you on their shoulder? Do they just want to get up and leave and give you a special wave? And even helping teach the child relaxation skills and strategies that they can use right before they attempt to take a nap within the school setting. So we're going to kind of have to go ahead and move on to our breakout rooms, but does anybody have an initial thought about a strategy that could be used in the home or the community that could complement what's happening at the school, that could be really right on point with these potential school strategies?
Maybe the therapist does some work with the parent and the child around the feelings, you know, whether it's causing night terrors or just bad dreams, or, you know, around the grief and that process of losing someone due to violence. Maybe the parent needs to be educated on sleep hygiene and what that pertains to or contains.
Mhm. Yes, absolutely. The parents at home are going to be great at supporting that nighttime sleep hygiene with strategies. Hopefully they glean from the community provider. And I thought you did a great job of really highlighting, you know, we want to complement each other, but we all have different roles. And the role of the therapist is to help create a space where that grief can be processed. Those specific fears can be brought to light and targeted so that they are less likely to be so impairing at night and during that sleep routine. So yes, great ideas. And I'm sure we could go on, but we're going to break out into breakout rooms with a really similar exercise. Will you move to the next slide just to make sure I'm not missing anything really key before we move on? Doesn't look like I am. So take a moment really quickly while Christy is placing us in our rooms to read through this prompt. Because when you get into your breakout rooms, we'll be working through this prompt and thinking through what are supports and skills that can be put into place at school, in the community, and at home to help this trauma-exposed child who's having emotion regulation challenges. Well, since do we think we have most everybody back, Christy? Looks like the numbers that we had. We were having some great conversation about everything, but we're kind of ending up with, you know, how challenging it can be to collaborate when school sees one thing and that's different than what the caregivers at home see, and that's different than what the community providers see. And I agree, that's incredibly hard to work through. And, you know, not to make that trite, because nothing about that is easy. And one thing I go back to in that moment is, how do I build as strong of a relationship as possible with the people that I'm collaborating with? You know, is there a trust issue maybe that we should be working on or thinking about, you know, what might be lying underneath some of this differing perspective and challenge getting on the same page. And sometimes the frustration comes from just how challenging it can be to address the child's needs. And that's certainly really understandable as well. Anybody else have any follow-ups or kind of loose ends from the breakout room that we should bring together in this space?
I think, Erin, one of the things that we talked about in group 2, and we're kind of wrapping up on it, I know that we'll revisit this next week, is just this idea that the strategy alone isn't enough. We have to consider if the strategy is feasible and what it's going to look like to implement, and then kind of how we're going to figure out if it worked. And then what we're going to do as we shift to, you know, sustaining the things that work, and then also kind of transitioning, right? So what happens, you know, we're in the summer and transitioning between what might have worked in one classroom and maybe next year it's going to look different, or things change over the summer. And so how do we kind of stay on top of that?
Yeah, absolutely. Well, let's go ahead and transition to our next slide. Nobody hesitate to put more in the chat if you want, because just kind of like last time, we'll do our best to circle back to lingering questions and concerns. I also want to make sure that I pointed out this kind of idea about skills and supports come from these trauma responsive support plans that the Kansas State Department of Education, there's a school mental health initiative that they've been funding throughout the state of Kansas. And they've developed these beautiful trauma responsive support plans that can actually be used in place of a functional behavior assessment. And they really draw upon this idea of getting consistent supports and skills in place across homeschool and community environments. So anyway, I just want to make sure that that attribution was really clear and that you all know how to kind of access those deeper trainings if you have interest. Next slide, please, Christy. We are in our last 5 minutes here together going to participate in a word cloud exercise. And so what you're going to do is, you're not going to type this into the chat, but there's a link that's showing up in the chat bar for you right now. We want you to follow that link that Jennifer just put in the chat. And once you follow the link, name something that you plan to try this week based on what you've gleaned from today's session. So take a moment to follow that link. I also don't think your name is actually going to show up in the word cloud. So.
And you can hit skip entering your name as well to make that faster.
And Christy, if people have like more than a one-word response, should they put dashes between them, or will it kind of show up together?
Yeah, it needs to be kind of all mashed into one word with either dashes in between or yeah, putting two words together.
And hopefully you can start to see the word cloud appearing. And if you're still entering your word, it'll continue to change and shift. See a lot of collaborate, and that focus on relationships is so key. It's the foundation of collaboration. We have to know each other. We have to trust each other. We have to put in the time. Communicate more, consistency, student-focused team building. Absolutely. I mean, kids sit at the very core of this. Do we know what they have to say about what will help, about what the problem is? And I love that somebody entered mindfulness again, because we have to be mindful when doing this work. There's a lot to keep track of. And if we're wanting to build relationships, being mindful of how we're feeling and how others are feeling is at the root of that. Respect, we're all human. Collaborative problem solving, that's even the name of a really cool approach to working with kids and families. I like that. Well, thank you all for participating in that. And I don't know if we have a final slide to put up with contact information or anything, but we have one final session in this series next week from 1 to 2:30, same time, June 15th, and hope to see you all there.